So disseminated intravascular coagulopathy, also known as DIC, is a very bad ending to certain diseases. So it's important to recognize because it tends to have a very poor prognosis, but it's not a disease in and of itself. It's caused by other things. So things that it's caused by are things that actually activate coagulation or that have diminished fibrinolysis or where you have a loss of anticoagulants, such as loss of antithrombin. So things to consider that could cause this include things such as severe trauma. So obviously trauma will release things like tissue factor, expose collagen, and all of those would obviously activate coagulation. Really severe inflammation, not just mild inflammation, but severe inflammation can in itself activate clotting because they have a few shared mediators. And so you might look for a patient who has overwhelming inflammation or a leukemoid response or really significant toxicity, a degenerative left shift, any of those things would then, if then there was evidence of DIC, that would be your potential cause, would be that inflammation. And again, it's because inflammation is actually stimulating coagulation and it overstimulates it. Kind of how trauma stimulates coagulation, it can run amok. Neoplasia can actually be a cause, and various types of neoplasia depending on what is actually being affected within the body. Again, you can have a loss of something like antithrombin, so a loss of an anticoagulant. And there's actually numerous other examples in humans, and we're not going to go into those. So animals that are bleeding for other reasons, so animals that have hemorrhage due to potentially another cause, even animals that get rodenticide ingestion with warfarins and that sort of thing, that could potentially cause it, like I said before, sepsis. Certainly other types of like hepatic failure, snake envenomation. There's lots of things that could potentially lead to DIC because it activates the clotting cascade. So the big ones again are going to be inflammation, trauma, neoplasia, and then anytime you're going to have a decrease in fibrinolysis. And that can be due to the above or other causes. And so how do you actually identify disseminated intravascular coagulopathy? So a few things happen in DIC. One, you consume your factors. And so when you consume factors, of course, that's going to make you unable to clot. And so you're going to see increases in clotting tests. So these include, obviously, PTT, so that will increase, and so will PT. Now, for exam purposes, we're going to say that they both always increase. However, in real life, sometimes only PTT increases, and there's a variety of reasons for that. We usually look for both of them increases, but sometimes in early cases you'll only see an increase of PTT, but we're going to pretend that all animals read the book and they both actually increase. That's supposed to be an increase right there. So they both actually increase. So you consume factors. You also consume platelets because, of course, you're making clots and you need platelets to make those clots. The other possibility is so that if you're actually consuming factors and bleeding, you can have a bleeding consumption as well. So you'll see a thrombocytopenia, and this thrombocytopenia can actually be mild or it can be severe. If it's just from bleeding, of course you expect it to be mild, but if you're consuming platelets to make all of these clots, it can be severe. So it's just one other thing that you look at. Those tests of fibrinolysis, you're going to expect that your D-dimer test is going to be increased or elevated. So the levels of D-dimers will be elevated because, of course, it means breakdown of cross-linked fibrin. And you'll also see increases in FDPs. And FDPs, again, are falling by the wayside because they're not as specific and can increase without cross-linked fibrin. So you can see an increase in D-dimers and FDPs, and then the red cell change you can see are schistocytes. And of course, schistocytes. So if you imagine here's, we'll pretend that this is our vessel wall and there's a fibrin clot in it, and our red cells are trying to pass through. They get sheared, and when they wind up on the other side, there are these jagged things called schistocytes. And if you imagine ripping up a red blood cell, they kind of look like this, or they have little kind of funny shapes, and those again are called schistocytes. So we look for a combination of these, although not all are always present. So one test I haven't really talked a lot about is the thrombin time. And so the thrombin time, remember, it actually measures this conversion of fibrinogen to fibrin. And we said that it really only is looking for fibrinogen that's functional and that there's sufficient amounts. Well, in DIC, fibrinogen actually decreases because it's consumed. So DIC would be a disease that would increase your thrombin time because you're going to decrease fibrinogen. So that's one thing to realize. And the other reason that it can be abnormal, along with the fibrinogen not working very well, is because FDPs actually bind to fibrinogen and make it not work as well. So you have abnormal fibrinogen both in terms of number and function. So just as a summary, DIC will cause consumption of factors, consumptions of platelets. So animals will have a bleeding risk. But again, because they're making clots, they will also have a risk of dying from thromboembolic disease, and that's what can cause them. So you can see a pulmonary thromboembolism. It can infarct various organs and cause death or severe disease that way.